which is a platelet plug formation, primary hemostasis. Very important. What do we have here? We have the cellular injury. Let me zoom out if I could. Give me 1 second. I want to zoom out for a better view. Okay. Let's look at platelet plug formation, primary hemostasis. If there was an injury, endothelial would damage, and there is a transient. First thing is going to happen is a transient vasoconstriction via neuronal or neural stimulation reflex and endothelin release. Remember the mechanism of endothelin? Endothelin is going to cause vasoconstriction. Endothelin vasoconstriction. Okay. So first thing is you got the vasoconstriction just because of injury to the endothelial cells or endothelial damage occurred. Second thing is that damage, now because you have the injury to the endothelium, now you have the subendothelial collagen, which is going to become exposed. Now this guy's exposed. Von Willebrand factor would bind to it. It's going to bind to the exposed collagen. Von Willebrand factor came from where? From the viable Palade bodies of the endothelial cells and the alpha granule of the platelet. So just think about it this way. These endothelial cells, they damage, they release von Willebrand factor, and that von Willebrand factor attaches to subendothelial collagen. Okay, that's the exposure. Now third thing is adhesion. What is adhesion? Now that von Willebrand factor, platelet would bind with that von Willebrand factor by a receptor known as GP1B, and the platelets are gonna bind. Okay, that platelets bind to that GP1B at the site of injury, only specific, meaning only at the site where the von Willebrand factor is and where the injury is. The platelets undergo, only specifically the platelet would undergo conformational change. What is that conformational change is? The platelet would release now two things. ADP, and calcium. Necessary for coagulation cascade and thromboxylate too. Three things. ADP helps platelet adhere to the endothelium. Okay, and this is one thing, and the other ones are activation. ADP now binds to the receptor which is present on the platelet, which is called P2Y12 receptor, and that P2Y12 induces the receptor on the platelet surface, and that receptor is, there's going to be a receptor coming here which is called, let's just GP 2B 3A 2B/3A. So we have one GP1B, but here now we have the GP2B3A. And how did we get that? The platelet release ADP. ADP stimulate a P2Y12 receptor that induces this receptor on the surface, which leads to rapid irreversible platelet aggregation. Now what's going to happen is rapidly other platelets are going to come and bind. No, actually what's going to happen here is they said is rapid irreversible platelet aggregation, but let's read the aggregation. There has to be some fibrinogen acting in between, so let's read that. So we got it here till we clear here. So let's read how things are going to work after this. Fibrinogen, which is in the blood normally, this is, let me change the color. Let's say this is fibrinogen, green thing. Fibrinogen is going to come and it's going to bind to this GP2B3A receptor and links the platelets. Now it's going to bind to that, and on the other hand, it's going to bind to other platelets GB2B3A, which is present on other platelets. Okay, and this is how aggregation is occurring now. You have the platelets and continuing all of them, just because of the fibrinogen getting bind to your GB2B3As. Now we should have some factors. Now they're talking about there's a balance is between the aggregation factors and the anti-aggregation factors. So the aggregation, the things that wanted to aggregate those platelets are the thromboxane A2, which is released from platelets, and decrease in blood flow. In case of injury, you have vasoconstriction that decreases the blood flow. That vasoconstriction, right, that decreases the blood flow. And it was done one thing from the neuronal stimulation, and second was the endothelin release, which caused that. Third thing is the increased platelet aggregation. Well, how did that occur? That occurred due to the ADP being there. ADP stimulated the GP2B3As and aggregated the other platelets. Now let's talk about the anti-aggregative factors. Anti-aggregative factors are the prostaglandin I2s, the nitric oxide released by the endothelial cells, okay, which are going to cause the vasodilation. Vasoconstriction is vasodilation is the anti thing, the PGIO2s and NOs. Increase in blood flow, okay, that's the second thing, and also decrease in platelet aggregation. Those are the anti-platelet factors. After aggregation, once you have aggregated all of this thing, what's going to happen is temporary plug stops the bleeding. But why are we saying it's temporary? Because it's unstable and it can easily be dislodged. So for that, we need secondary hemostasis to make it more stable, and with stability, you would have you would definitely stop the bleeding, and it's not going to be temporary. Okay, so let's talk about where's the secondary hemostasis. Okay, let's just read at the bottom. What do we have here? Thrombogenesis first, but here we just have formed till all of these points. We just formed a weak platelet plug. It has to get into the secondary hemostasis from the coagulation cascade, which is going to be coming afterwards. So let's just read the thrombogenesis now. Thrombogenesis. Again, same things they're telling us here. The first thing was the injury. Injury led to those endothelium to release those 1 milliman factors, which are going to bind to the thumb endothelial collagens at the exposure site, and those subendothelial collagens will bind to this 1 milliman factor, and then 1 milliman factor will bind to the platelet by GP1B. Platelet is going to release ADP thrombotic, they mentioned that or no, I don't know, but we already know that. Okay, ADP is going to stimulate, it's going to release ATP, which is going to stimulate those P2Y12 receptors, which are going to insert the GP2B3As on the surface. And once on the surface, these GP2B3As will bind fibrinogen, and that fibrinogen will also bind to other GP2B3As on the other platelet. So basically attaching these two platelets together by fibrinogen in between. And thromboxane A2 is a pro aggregator. Okay, it's going to aggregate more. It's going to stimulate platelet aggregation more and more. And ADP was doing this thing. And yeah, that's pretty much all. Let's talk about on the right side. What do we have? Formation of excuse me. formation of insoluble fibrin mesh. Aspirin would irreversibly inhibit the cyclooxygenase. Right here is the aspirin. It is inhibiting the COX irreversibly. So guess what? You're not making TXA2. You're knocking off TXA2. When you knock off TXA2, you cannot do platelet aggregation. So aspirin is doing inhibiting the platelet aggregation. Aspirin irreversibly inhibits the COX, thereby inhibiting thromboxygenase synthesis, while the clopidogrel, the prasugrel, ticagrelor, grelor inhibit the ADP-induced expression of the GB2B3As by blocking P2Y12 receptors. So here, these are, this is the clopidogrel, the prasugrel, and ticagrelor. They inhibit the ADP-induced expression of this GB2B3As by blocking. So they are basically blocking the P2Y12 receptor, and by blocking this, you're basically not letting the GB2B3As to go on the surface. Okay. And now the third type of drugs are, we have this eptifibatide and tyrofeban. They inhibit the GP2B3As directly. So here's the eptifibatide and tyrofeban and episiximab. They are inhibiting directly. Let's say even if they have on the platelet surface, they can inhibit it. So no fibrinogen can act on it, and there's going to be no platelet aggregation. Ristocetin activates the von Willebrand factors to bind to GP1B. Look at the ristocetin. This is stimulating the von Willebrand factor to bind to GP1B. Right? So with ristocetin assay occurs in von Willebrand. Okay, failure. Now, if you give this ristocetin and it's failed for the binding, you can say, okay, one thing, either we don't have von Willebrand factor, von Willebrand disease, right, and we have the Bernard's Solier syndrome, in which we don't have GP1B. Okay, and that, so we can diagnose two diseases by doing ristocetin test. So ristocetin test is either it's a von Willebrand factor disease or it's a GP1B disease. GP1B disease is called the Bernard Solier syndrome. Okay, now the third thing is the desmopressin. Desmopressin promotes the release of von Willebrand factor and factor 8 from endothelial cells. So desmopressin can be given in von Willebrand disease to see if they can be released from the endothelium, and von Willebrand factor normally has factor 8 attached to it, because normally if you have factor 8 alone, it's going to get destroyed. So von Willebrand factor has the factor 8 with it. So if you were to stimulate the endothelial cell, it's going to release the von Willebrand factor and factor 8. Okay, here's the thing that I'm talking about. Von Willebrand factor protects the factor 8. Volkswagen factories makes great cars. Okay, this is an important thing. Factor 8 is protected and carried by von Willebrand factor. Okay, so yeah, that's pretty much all we have here. Moving on with the coagulation cascade and kinin pathways. We have the PT monitors the extrinsic and common pathway, reflecting the activity of factor 1, 2, 5, 7, and 10. PTT monitors the intrinsic and common pathway, reflecting the activity of all factors except 7 and 9. Is it 8? 6, 7, 8. 8. Yeah, factors 7 and 8. Oh, my bad, it's 13, guys. Factor 7 and 13. 10, 11, 12, 13. Okay. 7 and 13. So let's read now. What do we have? Excuse me. Here we have the extrinsic pathway and the intrinsic pathway. Excuse me, guys. Extrinsic pathway. It gets stimulated by tissue factors. It is small, that's why I started here. So tissue factor stimulates and basically activates factor 7 into its active form, which is 7A. Excuse me. That 7A is going to go to the combined pathway and stimulate the factor 10 to 10A, activates the factor 10. Give me 1 second, let me get some water.